Now, the speaker is Dr. Nirmal Kanti Sharkar, graduated from Dhaka Medical College, Fellow of Medicine from BCBS, and obtained MD degree in cyst disease from Dhaka University. His publications are published in prestigious international journals. He also reviews international publications, and his activities make Bangladesh proud internationally. Currently placed as assistant professor in NIDCS. Please deliver your speech.
हेडरूम काटा हेडरूम
Thank you, Mr. Deputy, Honorable Chairperson of the session and dear audience, very good afternoon. Here I am with a topic, the transbronchial cryobiopsy for the diagnosis of interstitial lung disease, a very commonly encountered problem clinical scenario by us, but whether we can ultimately manage and diagnose these cases is a matter of question. Interstitial lung disease is a heterogeneous, as all of us know, it is a heterogeneous group of disorders having diverse pathogenesis, clinical features, radiological presentations, treatment options, and ultimately prognosis. But a small part of disease, which even after giving treatment proceeds to progressive pulmonary disease, that is the progressive fibrotic lung disease. And in 30% of the cases, more than 30% of the cases, the interstitial lung disease, even after getting clinical features and radiological findings, we don't go to a specific diagnosis. Hence, tissue acquisition is required for this patient for an ultimate diagnosis. There are variable methods of getting tissues from the lung for the diagnosis of interstitial lung disease. These are the bronchoalveolar lavage, transbronchial lung biopsy, surgical lung biopsy, and the latest armament is the transbronchial cryobiopsy. The first is the old weapon, that is the bronchoalveolar lavage. We know that this is a technique have very, very low adverse events, but the diagnosis of this modality is limited only for the alveolar pathologies, that is intra-alveolar diseases like infections, pulmonary alveolar proteinosis, hypersensitivity pneumonitis, eosinophilic pneumonia, organizing pneumonia, diffuse alveolar damage, and alveolar hemorrhage. But just think, if the disease is not located within the alveoli, it is extra-alveolar, it is peribronchial, it is the peripheral part of lung, what should we do? We have to take the tissue biopsy. What is the criteria of an ideal tissue biopsy? An ideal tissue biopsy must be minimally invasive, inexpensive, it takes large biopsy specimen, have minimal crush artifact, allows multiple biopsy sites to account for a spatial heterogeneity as seen in HRCT of the chest, and the safety is as equal as that of conventional bronchoscopy. Then the transbronchial lung biopsy, to be or not to be. Even we can do these things in our settings because it can be done by using the conventional biopsy forceps, and we can do it with or without the help of fluoroscopy. But the problem is that the tissue that can be gathered by this technique is only centilobular or perilymphatic, like the diseases, pathologies like lymphangitis carcinomatosa, sarcoidosis, organizing pneumonia, and diffuse alveolar damage. Another drawback of this technique is that small sample size can be gathered with each bite of the forceps. There is sampling error and crush artifact. To minimize this problem and gathering large tissue from the lung, surgical lung biopsy was adopted. It can be done either open lung biopsy or video-assisted thoracoscopic biopsy, having a diagnostic yield very high, sensitivity and specificity nearly 95%. Hence, it is considered as gold standard. But is it really gold standard? Because the question is here, because you can sample a small part of lung within each one procedure, and which minimal quantity of lung tissue should we take by a surgical lung biopsy is still debated. Moreover, it is associated with significant 30-day and 90 days mortality, increased IPF exacerbation, post-operative persistent air leak, and persistent post-operative pain. Not only that, this technique cannot be adapted in all the situations, especially in elderly age. If there is disease is very severe, there are comorbidities, and last of all, of course, the cost. And this setup that doing surgical lung biopsy is not available in all the part of our country. So, regarding transbronchial lung biopsy, should we throw it up? No. We should consider it still, because the old ways leave some things to be desired. Its diagnostic yield is only 20 to 30%. In comparing to surgical lung biopsy, it is 95% diagnostic rate. But the adverse events of transbronchial lung biopsy, like pneumothorax, is only 5%. But in case of surgical lung biopsy, virtually 100%. Moreover, the intraoperative, postoperative, and 30 and 90 days mortality is very high in case of surgical lung biopsy. So, this is our new armamentarium, that is the transbronchial cryobiopsy, which is added for the diagnosis of interstitial lung disease. You know, the cryobiopsy technique is the controlled application of extreme cold to the diseased tissue, whereby the tissue is converted to the intracellular ice crystal and leads to tissue damage. This technique was adopted in 1968, and since then, this technique has been used in the different respiratory diseases like taking biopsy, tumor debulking, airway foreign body removal, and removal of blood clot. But the concept of application of cryobiopsy for the taking parenchymal tissue is a relatively newer one, and it was adopted in the late 2000. Cryosurgery equipment, you know, it acts by Joule-Thomson law. That is, when a gas is compressed in normal temperature with high pressure, it is converted into liquid. And when this liquid gas, there is sudden release of pressure when it is passed through a narrow channel, there is sudden fall of temperature leading to crystal or ice formation. This technique is applied for the cryobiopsy technique. Here, the cooling agent is used, either nitrous oxide or carbon dioxide, which we can call the cryogens. Nitrous oxide is now obsolete due to regulatory obligations, and we use now the carbon dioxide. And you see, these are the cryoprobes. Different types of cryoprobes are available: 2.4 millimeter, 1.9 millimeter, 1.7 millimeter, and latest one is the 1.1 millimeter diameter cryoprobes. And different freezing times, depending on the use of cryoprobe, from the 4 to 10 seconds can be applied. We can do the procedure with or without sedation, and without application of fluoroscopy. The extra conduit can be used, that is, the bronchoscope can be introduced through endotracheal tube or through rigid bronchoscope. Yes, now the procedural aspect. The first, we have to diagnose, or we have to determine which site of lung from which we have to take the biopsy specimen by reviewing the HRCT scan. Then bronchoscope probe is introduced, that desired lobe and desired segment. Cryoprobe is introduced through the working channel up to the point where it is not progressed further. It is, here you see, this is the fluoroscopic view, and this is the tip of the cryoprobe. That is when it is not progressed further, it has touched the visceral probe. Then we will check the cryoprobe 1 centimeter, so that it is 1 centimeter beyond the visceral pleura. Then the foot pedal is compressed for 4 to 10 seconds so that the surrounding tissue is freezed. Then the cryoprobe is pulled, attaching the surrounding tissue in the tip of the cryoprobe, and all the bronchoscope, the whole the bronchoscope with the cryoprobe within the working channel is retracted. After retracting the bronchoscope, this tissue is then thawed into the normal saline, and the procedure is repeated for 2 to 3 times. The one problem is that when as the tissue sample is larger enough, it is attached at the tip of the cryoprobe and it cannot be removed within the working channel. So the full bronchoscope along with the cryoprobe should be retracted, and there is massive bleeding or bleeding, maybe massive bleeding or bleeding at that site. To minimize this problem, some operator use a second bronchoscope so that after doing the procedure, the second bronchoscope is applied, or if you don't have another bronchoscope, you have to quickly reintroduce the bronchoscope so that you can manage the bleeding by application of Fogarty balloon and or double lumen tube. Okay, now which is the target? Just imagine this is the cross section of the lung, this is the central airway, and this is the peripheral part of the lung. If we take the biopsy sample from the peripheral part of the lung, there is every chance of pneumothorax. If you take the sample from the center of the lung, you will not get the desired sample. This is the middle part and there is medium-sized vessel. If you take the biopsy sample from here, there the vessels are not supported by cartilage. So there is every possibility of massive bleeding. So this one is the desired site for taking the biopsy. Okay. Yes, and here you see this is the cryoprobe with the tissue at the tip of the probe, and this is the sample after thawing into the normal saline. And here you see this is the cryoprobe, and this is the 1 mm cryoprobe within the guide sheet. I will talk on the advantages of guide sheet later on. What is the good sample? We have taken the sample, but what is the good sample? Here you see this is the 3 types of sample. This is from the surgical lung biopsy, this is the cryobiopsy sample, and this one is the transbronchial lung biopsy sample. The sample size in surgical lung biopsies is larger one, and this is the intermediate between in comparison to that surgical lung biopsy, and this is the transbronchial lung biopsy sample. But this is not so small one. So a good sample should include intra-alveolar tissue and reflect the pathological part which is reviewed during the CT scan imaging, and at least the longest axis should be 5 mm. And for the best tissue processing, after getting the tissue attached with the cryoprobe, first you thaw the sample in the normal saline so the tissue is dislodged from the tip of the probe, then quickly but gently transfer it to the formalin, should not be sectioned grossly, and it should be embedded in paraffin along with the longest axis. Now, the diagnostic yield of cryobiopsy. This study was done by Antonio Alvarez in 2000 and published in 2017 in European Respiratory Journal, a prospective study on 106 patients. And interestingly, this procedure was done by using flexible bronchoscopy with mild, moderate sedation, without any endotracheal tube or rigid bronchoscopy or general anesthesia, and most importantly, without fluoroscopic guidance. And a definitive diagnosis they could got in 86% of procedures with a very minimum pneumothorax rate of 4.7%. And this is the review of 20 studies starting from 2009 to 2017. Here you see all the studies, and the diagnostic yield of the lowest diagnostic yield was 50.6 and the highest one was 100%. And the average diagnostic yield was more than 50.6%. And what about the newer probe? I have talked on 1.1 millimeter probe. You have already heard that the one problem of cryobiopsy is that when I pull the cryoprobe, there is and the bleeding from the surrounding areas. And we have to pull the whole bronchoscope, then reintroduce it. So this 1 or 2 minutes, the patient remain unattended and we can't manage the bleeding. By using this 1.1 millimeter cryoprobe, it is passed through a guide sheet. Just Mr. Reporter sir, I will take 5 minutes more to, if you kindly permit me. Okay, so just think about the brush sample that we do during the bronchoscopic procedure. This 1.1 millimeter cryoprobe is introduced through the guide sheet. We take the biopsy and retract the probe within the guide sheet without retracting the bronchoscope. That is, bronchoscope is in its own place. So if there is bleeding, we can instantaneously manage the bleeding by application of adrenaline, ice cold lavage, or applying Fogarty bleeding. And this new probe technique was studied and it was published in Respiration, and it was a prospective randomized ex vivo animal model study, and they compared the effectiveness of 1.1 millimeter cryoprobe with transbronchial forceps biopsy, and biopsy sample could be obtained in 93.3% of the cases in TBCB and 79% in TBFB procedures. So, in comparison to surgical lung biopsy, there were only 2 studies in the literature. The one study, that's this by Romagnoli, and it was they studied 21 patients and they did both surgical lung biopsy and transbronchial cryobiopsy, the same procedure, same patient, and involving the 2 doses. But the histopathological agreement was in 38% of the patients, and there was the selection bias. Another important study, the Skoldes trial, it was a multi-center study involving 65 patients, and the diagnostic agreement that could got in 70.8% of the cases, and MDD agreement in 76.9% of the patients. But till date, there is no head-to-head clinical trial. Okay, this diagnostic yield is very good, but how safe is it? This Australian cohort involved 5 Australian tertiary care hospitals from 2013 to 2017, and to determine the safety profile of transbronchial cryobiopsy included 121 patients. And in 84 patients, that is 66.7% patients, they could discharge the patient on the same day of the procedure. In 14.9% patients, there was pneumothorax, but altitude needed only 10.7% of the patients. And moderate bleeding occurs 13.2%, and severe bleeding only 1 patient. And the diagnostic yield was 66.1% of that cohort. So the complications may be pneumothorax, variable rates of pneumothorax up to 9%, severe bleeding, exacerbation of ILD, and procedural mortality. So mortality can occur in case of transbronchial cryobiopsy. This was the only study that was done in the Vanderbilt University from 2012 to 2018 to see the 30-day and 90-day mortality among the 176 patients. And they found that 30-day mortality was 2.3% and 90-day mortality 2.8%, and the risk factor was poor diffusion coefficient, that is less than 35%. So, why we should not do the transbronchial cryobiopsy? The absolute contraindications are if there is any known bleeding diathesis, the patient is on anticoagulant or antiplatelet drugs, and there is thrombocytopenia. And the relative contraindications are poor lung function, that is FVC less than 50% and FEV1 less than 50% predicted, DLCO less than 35% predicted, and the patient has pulmonary hypertension, that is estimated systolic pulmonary artery pressure is more than 40 millimeter of mercury. And at the end of my presentation, this is the ERS 2022 recommendation regarding the use of transbronchial cryobiopsy, and they have opined that TBCB should be suggested as a replacement test for surgical lung biopsies. TBCB is the first choice for the patient who are not eligible for surgical lung biopsy. SLB, yes, we can do the SLB if the initial TBCB is inconclusive, and TBCB operators should undergo extensive training. And this is the take home. Transbronchial cryobiopsy is a minimally invasive technique for acquisition of lung tissue. In expert hand, it has a very good diagnostic yield and have a minimal complication, have a very good and high safety profile, and TBCB is a valid alternative to surgical lung biopsy. And last but not the least, this is just like one type of canvassing. Yes, I do cryobiopsy. Here is my mentor, Professor Saidul here. Me and Professor Saidul, we both do cryobiopsy, and I think a lot of guys here and our seniors, juniors and colleagues, it's a very safe procedure. If you want, you can also do cryobiopsy so that we can diagnose